Hello, I'm pleased to welcome you today to our special event on treating obstructive sleep apnea. I'm Brian O'Rourke, the President and Chief Executive Officer of CADIF. Before we get underway, I want to acknowledge that our in-person session here today is being held on the traditional and unceded territory of the Algonquin Nation. Obstructive sleep apnea, or OSA, there's going to be some acronyms thrown at you today, is a sleep disorder that affects as many as 1 in 4 Canadians. So it's an extremely important and relevant topic. So it's not surprising that this webinar has generated considerable interest. We have more than 400 people signed up, both here in person and online, and representatives from all over the world attending. CADIF is committed to providing decision makers at all levels of the healthcare system, patients, clinicians, policymakers, with the objective evidence and expert advice that they need to make informed decisions about the optimal use of drugs and medical devices. And these are incredibly and increasingly difficult decisions, given the need to consider clinical effectiveness, cost effectiveness, access for patients, patient preferences, appropriate use, ethical issues, affordability, and a whole range of implementation factors. The challenges are often more pronounced for medical devices because the treatment options can be very diverse, evidence is often lacking, and decision points are more numerous, and the costs can vary considerably. With obstructive sleep apnea, for example, the treatments can range from lifestyle interventions to surgery, plus several different medical device options, some of which are publicly funded, some of which are not publicly funded. To provide evidence-based guidance in the management of obstructive sleep apnea, CADIF conducted a very comprehensive health technology assessment, which was then used as the basis for a set of recommendations from CADIF's expert committee, the Health Technology Expert Review Panel, chaired by Dr. Sterling Bryan from British Columbia. You can download the Health Technology Assessment Report and the recommendations document from our website, cadif.ca, and this is all publicly available at no cost. Today you have an opportunity to hear from the lead researcher for the Health Technology Assessment, Dr. Joanne Kim, who is a clinical research officer at CADIF, and from a clinical expert, Dr. Sachin Pendarkar, who is an associate professor of medicine and community health services at the University of Calgary. Dr. Pendarkar helped develop the recommendations for our report. Following the two presentations, you'll be able to ask questions, and those of you attending here in person will have an opportunity for some informal chat with Dr. Pendarkar and Dr. Kim after the presentation. So I'm very proud of CADIF's work on this topic. I believe it fills a real knowledge gap in Canada and will help support access, appropriate use, and affordability in this important clinical area. Now please join me in welcoming the moderator for today's session, Sarah Garland, who's CADIF's knowledge mobilization lead for this topic area. Sarah?
Thank you for that introduction, Brian. And thanks again to everyone who could be here in person or online. Regarding the format of today's talk, we'll have about 10 to 15 minutes for questions at the end of our session. And for online participants, you could submit questions at any time using the chat function on your screen. Also, this is a social media friendly event. So if you'd like to join the online conversation, you can tweet at CADIF_ACMTS using the hashtag OSA. And just to note, neither myself nor any of the speakers have any conflicts of interest regarding this work. And with that, I'd like to introduce Dr. Joanne Kim. Joanne began working at CADIF in 2015 and has a PhD in health services research and health economics from the University of Toronto. Welcome, Joanne.
Just going to scroll through. Well, thank you for the introduction, Sarah, and good afternoon, everyone. It's a pleasure to be here on behalf of my team. If I'm not mistaken, our report takes the cake for being the longest HTA report that CADETH has produced, with 566 pages in length. And today, I have the privilege of summarizing it in 10 minutes. But needless to say, there's so much more information in the actual report, and I strongly encourage you to go to our website and access the report and the rich information that it presents. And perhaps we can set another record at CADETH with the most downloads. So we all understand the importance of sleep. I love sleep, and so I definitely can't function without a good night's sleep. So it is no surprise, as Brian mentioned, that obstructive sleep apnea, also known as OSA, is a hot topic today. OSA is a common sleep disorder, and as Brian mentioned, it affects up to 1 in 4 Canadians. And when people with OSA fall asleep, the muscles in their throats relax, causing their upper airways to collapse. As a result, their breathing stops and restarts throughout the night, and that prevents them from getting a good night's sleep. Symptoms of OSA include snoring, excessive daytime sleepiness, and impaired memory. Anyone can develop OSA, but there are definitely risk factors such as obesity, being male, and aging. Left untreated, OSA can lead to serious health complications such as hypertension, stroke, and heart failure. Sachin, our clinical expert, who will speak shortly, will offer more details on this from a clinical perspective. Now, there are numerous treatment options available, and the slide to my right mentions just a few of them. The most commonly used intervention, which is considered the gold standard, is CPAP therapy. It continuously forces air into the upper airway to prevent the soft tissues from collapsing. There are also oral appliances, which adjust the position of the jaw or the tongue to open up the airway. There are more invasive interventions as well. Surgical options include maxillomandibular advancement, or MMA, as well as genial tubercle advancement, or GTA, that permanently pull the lower jaw or the base of the tongue to create more airway space. Other interventions include EPAP valves, which are disposable devices that use a patient's own breathing to open up the airway, as well as lifestyle modifications such as diet, exercise, and positional therapy. So determining which treatment option works best for individual patients remains a significant challenge across Canada. Based on our consultations with various Canadian jurisdictions, we learned that providing a review of the evidence as well as expert recommendations on the treatment of OSA would help clinicians, policymakers, and patients decide how to best use the available treatment options in Canada. So we set out to answer the following policy question. What is the optimal use of PAP devices, EPAP valves, oral appliances, surgical interventions, and lifestyle modifications for the treatment of OSA in adults? To answer this question, we conducted an optimal use project, which in the CADETH devices world means an HTA with recommendations from HTERP, our Health Technology Expert Review Panel. For our HTA, we looked at clinical and cost effectiveness of the various treatment options for OSA, as well as the perspectives and experiences of patients, family members, and caregivers, ethical issues, implementation issues, as well as environmental impacts associated with the various treatment options for treating OSA. HTERP members then reviewed the evidence, considered all elements of the HTERP deliberative framework, and developed consensus-based recommendations through discussion. In my remaining time here today, I'll quickly review the evidence and provide you with the HTERP recommendations. According to the clinical effectiveness data, all treatment interventions that we examined were effective at reducing excessive daytime sleepiness, although severe cases of OSA may benefit more from CPAP versus an oral appliance called MAD. CPAP also appeared superior at reducing OSA severity, And for severe cases of OSA who have failed PAP therapy and are eligible for surgery, the MMA surgery with or without GTA may be the most effective at improving both excessive daytime sleepiness as well as OSA severity, although these findings are from small and controlled studies, and we must keep in mind the invasive nature of surgery. In the cost-effectiveness study that our own Bernice Choi performed, is Bernice in the audience? Awesome. We found that the cost-effectiveness of treatment strategies for OSA was found to depend on patients' baseline OSA severity. At a willingness to pay threshold of $50,000 per quality-adjusted life year, for mild cases, no treatment was the most cost-effective. For moderate cases, the MAD oral appliance was the most cost-effective on the lower end of severity, and the MMA surgery with or without GTA for the upper end of severity. For severe cases, PAP devices were the most cost-effective for the lower end of severity, and the MMA surgery with or without GTA for the upper end of severity. In addition to the clinical and cost-effectiveness data, we have rich information in the other sections of the report. The patient perspectives and experiences review conducted by our moderator, Sarah Garland, as well as Tamara Rader, who's there, revealed that a range of characteristics and factors influence whether people seek and initiate treatment for OSA. Those factors include patients' prior expectations and beliefs about treatment, the social support they have available, as well as their lifestyles. The review also revealed that treatment interventions for OSA require people to adapt their daily routines and relationships, and that some people are able to integrate the interventions into their lives and experience benefits, while others are unable to do so. The review of ethical issues conducted by an external ethicist, Catherine Duthie, and our own Ken Bonds, not sure if Ken's here, revealed several key values that are relevant to how access to OSA treatment interventions are organized and delivered. These values include respecting individual autonomy, maximizing benefits and minimizing harms for patients and populations, distributing benefits and burdens of healthcare resources fairly, and stewarding scarce resources. The capacity for patients to benefit from most OSA interventions relies heavily on patient behavior, so patient context is perhaps unusually significant for these technologies. Treatment interventions for OSA have been shown to offer benefits to OSA patients and reduce overall costs from our own review, and therefore appear to live up to the values conferring benefits at a population level and stewarding scarce resources. According to the implementation issues review that we conducted, that was conducted by our Janice Mann, one of the biggest issues found was the difficulty in accessing sleep specialists and sleep labs to obtain a diagnosis in order to seek appropriate treatment. Barriers for CPAP included costs and patient discomfort, while supports included patient education and ongoing support. Barriers for oral appliances included lack of physician awareness, dental health requirements, and the need for regular reevaluations. Last but not least, a review of environmental issues conducted by Kelsey Seal, who's also in the audience. There was limited information that was found on environmental considerations, but they included CPAP manufacturer adoption of green shipping and production methods, and creating products that are more energy efficient and recyclable. So based on these findings, HTERP generated the following recommendations. For patients with mild OSA who are overweight or obese, HTERP recommends lifestyle interventions. For patients with mild OSA who are not overweight or obese, HTERP does not recommend active treatment. For patients with moderate or severe OSA, HTERP recommends CPAP. For patients with moderate or severe OSA for whom CPAP is unacceptable, oral appliances are recommended. HTERP does not recommend surgical MMA in patients with OSA unless other interventions have failed or are unacceptable to the patient. So that's a 10-minute summary. And again, I encourage you to explore our reports and learn more about the findings. And thank you for listening. I'll now hand it over to Sarah.
Thank you, Joanne, for that excellent overview of CADIS OSA project and for cramming such a large document into such a short amount of time. So now we'll hear from Dr. Sachin Pendarkar, who will give us insight into what this work means for clinical practice. Sachin is an associate professor of medicine and community health services at the University of Calgary. He is a sleep physician at the Foothills Medical Center, Sleep Center in Calgary, Alberta. And he received his medical degree from the University of Western Ontario in internal medicine training at the University of Toronto before completing a respirology and sleep fellowship at the University of Calgary. He is a health services researcher and executive member of the Canadian Sleep and Circadian Network. Welcome, Sachin.
Thank you, Sarah, for that introduction. I'd also like to thank CADIS for the opportunity to participate in this review and for inviting me to speak to you today, and to all of you for attending. Most importantly, I want to acknowledge and thank CADIS on behalf of my colleagues and patients with obstructive sleep apnea for drawing attention to this really important topic. So providing a clinical context, it's probably worth providing some clinical background for the topic. So the first comment is that obstructive sleep apnea is very common. When you look at population-based studies, the prevalence ranges from 10% to 25%, depending on the population being studied and the definition of obstructive sleep apnea. A rapid review performed by the Public Health Agency of Canada in 2009 suggested that 3% of Canadians carried a diagnosis of obstructive sleep apnea. But based on characteristic symptoms and signs that would put people at higher risk of sleep apnea, as many as 26% of Canadians are at high risk. This discrepancy, 3% versus 26%, would fit with other literature that suggests that as many as 80% of patients with obstructive sleep apnea remain undiagnosed. And the prevalence has increased when you look at the rising prevalence of overweight and obesity in the general population. So the graph here to my left looks at other common chronic conditions compared to obstructive sleep apnea in terms of prevalence in Canada. So what we see is hypertension, COPD, asthma, and diabetes, each with population prevalence in the range of 5 as high as 22% with hypertension. On the far left, you'll see obstructive sleep apnea based on this PHAC data. About 3% of the population has a diagnosis. But when you actually look at what the potential burden of disease is based on risk, you see that it's quite a bit higher, as high as 26%. In addition to being very common, obstructive sleep apnea has significant clinical consequences if untreated, and Joanne highlighted a few of these a moment ago. What we know is that patients with untreated OSA have poor quality of life. They have an increased risk of depression. Their risk of motor vehicle collisions across the severity spectrum is increased. The severity of OSA is increased. In moderate to severe disease, there's an increased risk of hypertension, cardiovascular disease, and stroke. And more recently, we've learned about reduced workplace productivity and occupational injury associated with untreated sleep apnea. So as you can see from this list, in addition to clinical consequences that a patient themselves might experience, there are also some implications for public health and safety, and I would submit that that's more so than with other chronic conditions. So the question of who to treat, what the expected clinical benefits are, and what the cost effectiveness of therapy is actually very relevant for clinicians and healthcare decision makers. So Joanne has already highlighted the recommendations and the process at arriving at those recommendations. Looking at this with a clinical lens, there are a few questions that come to mind, and I've listed them here. So the first is, who do we treat? To which patients do we offer treatment? When we do offer treatment, what treatments should we recommend, and what is the role of the different therapies in the overall management of obstructive sleep apnea? And finally, what are the funding implications and their impact, or funding implications for patients? So the first is the question of who to treat, and I've simplified this to think about what severity of patient do we treat. The recommendation in a nutshell is to offer treatment to moderate to severe patients with moderate to severe OSA, and I'm talking about things like CPAP, mandibular repositioning devices, et cetera. And that would suggest, that would be relevant for patients with an apnea-hypopnea index. So this is the number of events per hour, respiratory events per hour, of greater than 15, normal being less than 5 per hour. And the first comment here is, there are a few caveats. The first is that when you look at symptoms, when you look at things like inattention as measured by psychomotor vigilance testing, these actually don't correlate very well with the severity of sleep apnea as defined by an apnea-hypopnea index. So the graph on your left is looking at the relationship between the severity of obstructive sleep apnea and sleepiness as defined by the Epworth Sleepiness Score, which is the common sleepiness scale that is used in the sleep literature. And what you can see here is that when you go up from no OSA to mild, moderate, and severe, there's actually no correlation between the severity and sleepiness. So patients with very severe disease may not have much in the way of symptoms. Patients with very mild disease may have lots of symptoms. And so it can be quite difficult to tease that out based on severity alone. The graph on the far left looks at psychomotor vigilance testing. So this is based on mean reaction speed. So this would be, you're looking at a screen and every time a green light flashes, you hit a button as fast as you can. So some sense of reaction time, which as you can imagine would have importance in terms of things like driver safety and occupational safety. So what we see here is actually, based on that graph, a relationship. There is a relationship, a trend between across the severity spectrum when it comes to psychomotor vigilance or reaction speed. But the authors of this study, which was published last year and is out of Iceland, actually did some further analysis and found that that relationship was completely driven by the group with severe OSA. So when you take that group out, when you look at mild, moderate, and even people without OSA, it's actually quite difficult to differentiate clinically important measures based on severity alone. Now, we also know that up to 25% of patients with obstructive sleep apnea have minimal or no symptoms, yet may demonstrate signs of inattention. So with this in mind, from a clinical perspective, I think it's really important to evaluate sleep symptoms, to look for signs of inattention, near misses at work or on the road, for example, and consider a trial of treatment if present. The second issue relates to this number, the apnea-hypopnea index. So how do we define severity? Now, it was the number that, it was the way that severity was defined in the report, and I think that's very appropriate because it is the most common and well-recognized way of defining severity. Oops, sorry, back a bit. I would just draw attention to the fact that it's not the only measure. And what, case in point would be the relationship between the apnea-hypopnea index, so that number that defines the severity of OSA, and age. As you get older, the number gets higher for patients with sleep apnea. In fact, the normal number goes up a little bit. But when you look at the relationship between obstructive sleep apnea and cardiovascular disease, those relationships or those associations are actually much stronger in younger patients. So right off the bat, depending on your age, the number may or may not be clinically relevant. So, or maybe more or less clinically relevant, I should say. So there is a lot of interest at present in defining phenotypes of obstructive sleep apnea. So trying to look at this from a precision medicine approach, not just taking the number, but looking at other factors that might influence treatment decisions and also prognostication. So the second issue that comes up, and I'll bring up the slide again that highlights the recommendations from the review, is the role of different treatments. So this was a really comprehensive review. It was really quite a delight to be part of it because it looked at all different interventions, lifestyle interventions, CPAP, mandibular repositioning devices, and different surgical therapies. I want to talk about a couple of points related to that. First would be lifestyle interventions. And so for the most part in this population, we're talking about weight loss programs or weight loss interventions in patients that are overweight or obese. So we know that there is a correlation between weight loss and OSA severity. So that would suggest that there is benefit for patients to lose weight. But we also know that weight loss has health benefits in other conditions that are commonly associated with obstructive sleep apnea. So diabetes, hypertension, heart disease, for example. So to the extent that a lifestyle intervention program influences weight loss, I think it's a helpful thing, and it's something we should be recommending. And certainly in clinical practice, that is something I discuss with all of my patients. The review suggests that the programs themselves have a role in managing obstructive sleep apnea, in the management of OSA, both in terms of the improvement in severity and possibly for sleepiness as well. And I think it's a great reminder for clinicians that we don't always need to look at pharmacologic therapies or devices, technological treatments when we think about managing a condition like sleep apnea. The second issue related to which treatments is what do we do when we're recommending an active treatment? And I sort of put that in air quotes because lifestyle intervention is certainly an active treatment. I'm talking about CPAP, dental devices, et cetera. The traditional approach would be to try CPAP and to use a mandibular repositioning device or a dental device if the patient is intolerant of CPAP. And more recently, we've learned about specific surgical interventions and surgical procedures that are actually quite different than the ones that were used 20, 25 years ago. The review, I think, supports a similar approach or supports this approach based on similar improvements in sleepiness and probably a greater reduction in apnea-hypopnea index, or the severity of OSA. CPAP is recommended as the first line. And certainly in patients with severe OSA, it confirms that CPAP would definitely be the recommended treatment. But I think that we need to, again, look at other considerations, other clinical factors when we're making treatment decisions. And I've listed a few of them here. The first is, and I would argue probably the most important, is tolerance. So if someone doesn't tolerate a therapy, they're not going to wear it, not going to use it. And that obviously impacts their adherence, which is really the gateway to all the health benefits of treatment for obstructive sleep apnea. Now, we know that there are some studies that reveal that mandibular repositioning devices, so the dental devices, may be better tolerated than CPAP. So you have this trade-off of maybe the CPAP treats the sleep apnea a little better, but it's better tolerated, less well tolerated than a dental device. And so there is certainly a rationale for suggesting mandibular repositioning devices as a first line in some patients. I would speak on behalf of some of my sleep colleagues. Certainly in Calgary, our experience has been that with appropriate clinical support, CPAP adherence can be quite good. And from a very practical perspective, a dental device is a custom-fitted device. So you sort of commit to it at the outset. Whereas CPAP, it's a mask with a machine that you can try to see if you tolerate it, to see if you derive symptomatic benefit. And at the end, if none of that's working and you really decide you don't want to go forward, you can hand it back. Now, that's the model that we have in Alberta. I think that exists in a lot of other provinces across the country. So it is an opportunity to at least see what the impact of treatment is without having to commit wholeheartedly to the treatment. The second issue relating to adherence is patient preference. So there is quite a bit of emerging literature from Canada actually looking at how preference for CPAP versus mandibular repositioning device can impact adherence. A lot of that evidence wasn't included in this review because of the timelines of the review itself, but we know from other diseases that there is evidence that engaging patients in their care plan and their management actually improves adherence and satisfaction with therapy. And those of us in clinical practice would absolutely agree. CPAP is a mask you put on your face with a machine blowing air. A mandibular device is a jaw device that pulls your jaw forward, an oral device that pulls your jaw forward. If you don't want to wear these things, you're probably not going to. So certainly buy-in or engagement by the patient is really an important thing. The third issue, which I'll talk about briefly here and we'll come back to in a moment, is cost. So in Canada, if you look at government funding programs or private insurance coverage, CPAP tends to be more readily funded than mandibular repositioning devices. So depending on the funding model in the local jurisdiction, CPAP may be a preferred therapy on that basis. Now, a big question is where does surgery fit in? What's the role of surgery? And again, the review looked at a number of different techniques, surgical techniques, and the most promising, as Joanne indicated, is this maxillomandibular advancement. So basically a repositioning of the jaw, and it's a multi-stage surgery. It's important to acknowledge, as Joanne mentioned, that the studies that have looked at this particular intervention tend to be small. They include select populations who are generally intolerant of other therapies, and really have looked at the outcomes of apnea-hypopnea index, so severity of OSA and sleepiness, which are important outcomes, but what we're really lacking is the long-term health data that we see with some of the other therapies, impact on hypertension, cardiovascular disease, et cetera. So the recommendations suggest that surgery may be cost-effective in different groups of patients with moderate or severe OSA, but I think it needs to be taken in this context. Where I think surgery really fits in is for patients that are unwilling or unable to use CPAP or mandibular repositioning devices. But I think those decisions need to be made with the patient with some important conversations about the risk and the evidence. Those are really important contextual issues. I think it's also important to acknowledge that, like other surgical procedures, appropriate training of the surgeons doing the procedures is really important. There are training programs in sleep apnea surgery in North America. And case volume is going to be important as well. So you want centers that are experienced with these procedures to do the surgeries, because they are quite invasive and quite complex. So the third issue and last issue that I'd like to discuss today is that of the impact of funding policies on obstructive sleep apnea treatment. So the review, as Joanne discussed, demonstrates that therapies for obstructive sleep apnea are highly cost-effective for moderate to severe OSA. There are some differences depending on obstructive sleep apnea severity, but overall, as a clinician, I think this is a really welcome finding to show that the treatments that we prescribe are actually cost-effective for the system. But it also highlights the fact that there's little to no public funding for obstructive sleep apnea in many parts of Canada. So the cost effectiveness that is sort of highlighted in the report, the numbers that are highlighted in the report would put obstructive sleep apnea in the category of medical conditions that might be funded by government programs or by provincial governments and territorial governments. But as of right now, Ontario and Manitoba are the two provinces that have well-established funding programs, and in most other places in the country, we are looking at mostly private funding, either through out-of-pocket or through private insurance. Now let's put that in context for a patient. The cost of CPAP or a mandibular repositioning device, when you look across the country, ranges from $1,000 to $3,000. Now right off the bat, that's prohibitive for many patients in the absence of private insurance. And we also see in the clinic that this cost will discourage patients from pursuing therapy. They'll say, you know what, I'll put up with my sleepiness. You know, I'm a little bit sluggish in the evenings. I don't have the same time or energy to spend with my family as I might otherwise. I'm falling asleep at my desk. But you know what? This is a really expensive therapy. I'm just going to go without. We definitely see that in the clinic. So at the end of the day, patients who don't have the ability or willingness to pay are at risk of poorer health outcomes and increased use of healthcare resources. And will add to that the risk of motor vehicle crashes, occupational injury, and suddenly we're talking about things that, policy implications that affect other people besides the patients themselves. We recently did a focus group with some patients in Calgary, and one of the patients made a really insightful comment about the fact that we have regulations around driving safety and workplace safety related to your ability to, competently and safely operate a vehicle. Some of these are government mandated, and yet we have governments that don't fund these programs in a lot of places, Alberta being one example, that restrict patients. They get caught in the middle, and I think that's a really important thing for us to remember. Now, a related issue around public funding, is that when we don't have public funding programs, the costs of therapy are largely driven by market forces rather than government negotiated prices. So Sarah mentioned the Canadian Sleep and Circadian Network, which is a national group that I'm affiliated with. So in partnership with the CSCN, myself and some colleagues from across Canada have recently completed a high-level national comparison of funding models and costs of therapy for sleep apnea. And what we found is that there's a high degree of variability in the cost of CPAP and mandibular repositioning devices. Now, I mentioned the numbers $1,000 to $3,000, and some of that is related to, if you will, bells and whistles. So features on the machine or on the dental device that might improve tolerance or comfort. But a lot of that is actually driven by just where you live, regional variability. And so it demonstrates to me that where you live in Canada directly impacts your ability to access what is essentially a clinically and cost-effective therapy, clinically beneficial and cost-effective therapy. Now, I'm speaking to you as a clinician, so I'm here to provide a clinical context, and you can obviously see that I have some thoughts about the policy implications of a report like this. But I think it's important for clinicians to look at these kinds of reports and to advocate for our patients and to advocate for system changes to help our patients. So from that perspective, I'm very encouraged by the finding of cost effectiveness of moderate to severe OSA. I think it makes a really important contribution to ongoing conversations within the provinces and territories and nationally about public funding for treatment of OSA. So in summary, I think overall this is a very helpful review for clinicians. I've pointed out some nuances, but I think it's a really great document, and I'm really proud to have been part of it. I think it informs important conversations that clinicians can have with their patients around who we should treat, why we should treat them. The summary there, at least moderate to severe patients should receive treatments like CPAP and mandibular readvancement, possibly surgery, for symptomatic and health benefit. We can have conversations about what the best options are for treatment. So again, CPAP mandibular repositioning device is probably at the front of that list. But I think it's an opportunity to introduce upper airway surgery with now a good summary of evidence behind it to say that it's a possible therapy. It's an option for people that are intolerant or are not accepting of CPAP or mandibular repositioners. The second conversation that I hope comes from this is that conversations between and among clinical stakeholders and healthcare decision makers about funding models. The report highlights that these are cost-effective treatments, and they definitely have the ability to have significant positive impact on the health and safety of Canadians. So with that, I'll conclude and turn it back over to Sarah. Thank you very much.
So thank you, Sachin, for your presentation. I think you're uniquely positioned to offer your insight into this clinical area. So now we have plenty of time for questions. And again, a reminder for anyone who's online, you can submit your questions using that chat function on your screen. And just for people who are in person here, a reminder to use the microphones on your table. And if you could state your name and who you're representing, that would be great. So let's turn to the room here and see if there are any questions from our audience today. Brian, yeah.
Always like to get things started. So Brian O'Rourke from Cardiff. Joanne, as we started this project, we saw very soon that there was a lot of interest in this topic from the medical community as well as the dental community. So my question is more for Sachin. Have you started to see a more collaborative approach now between the dentists and the physicians involved in treating patients? Do we have work to do in trying to communicate to patients on which approach to take and who do they need to see first to get diagnosed and treated?
That's a great question. Thank you for that. So absolutely, I think historically we have had these silos of care for patients with OSA. Dental device if you happen to come, see your dentist. CPAP if you see a sleep respirologist or a non-surgical physician, and perhaps upper airway surgery if you see surgeons. I think increasingly we are seeing collaborations occurring at the clinical level. Certainly, I can speak on behalf of our center, other centers, speaking to colleagues across the country, that there are collaborations between the groups. So that is really, really quite good. I think that there's still room to do more and better. There are lots of perspectives on how these treatments fit together. Some think that mandibular repositioning devices should be, farther up the line than CPAP. Others think the other way around. So there's a little bit of, I think, more work to do to bring the communities together, but it's happening, and I think in some places it works very well. Your question about having how do we inform patients about what the options? I would extend that to say that it's not even just about the patients, but many physicians that are thinking about sleep apnea, or extend to physicians, other healthcare providers, nurse practitioners, nurses, et cetera, who are thinking about diagnosing and treating sleep apnea are not clear on what the appropriate therapies are and when to use them. So I think that we can absolutely do better in terms of educating the population, but the healthcare community as well, in terms of what treatments to use and when.
All right, thank you for that. Are there some other questions in the room here?
Yes, talking about what you were just discussing, I was diagnosed with severe sleep apnea. But before my diagnosis, I was for 8 months sent to a chronic fatigue clinic for 8 months before I was properly diagnosed. So I believe the physicians should be more aware, or I don't know if it has anything to do with the waiting time in regards to getting in to do the testing. But I just know I spent 8 months seeing a chronic fatigue when it ended up being severe sleep apnea, where they write out a report to Ministry of Transportation with my sleep apnea. Just saying, more awareness to physicians.
Yeah, yes, please.
Again, a great point, and I would say in the clinic we we definitely see patients that have had a diagnosis of chronic fatigue, depression, have been tried on treatments, you know, I'm not saying we solve them all by giving them a diagnosis of sleep apnea, but certainly it's something that we see in the clinic. I think it speaks to how common the condition is, and how many different ways sleep apnea can impact any one individual. It might be, you know, I mean, we talk about cardiovascular disease and diabetes and high blood pressure, and those ones I think we've got a little bit more of a recognition of, but let's talk about depression, let's talk about fatigue, and that's just the people that are presenting for medical attention. There's the whole group of people that think, well, maybe I just don't get enough sleep at night, my kids keep me awake, I'm stressed out at work, when in fact there's actually an underlying medical diagnosis that needs to be made. So I think it's a great point, and we definitely see that in clinical practice.
What stage are you at sleep apnea where it's required by the doctor to report it to the Ministry of Transportation? What's the guidelines there for severity, moderate?
Yeah, there's actually a Canadian, the Canadian Thoracic Society has a position paper on this exact issue that was published, I think, 3 years ago. I mean, the bottom line is it depends on the jurisdiction. So the provinces, the individual ministries of transportation have their own guidelines. So in Ontario, I think the duty to report is actually fairly high or strong. In Alberta, what we're asked to do is inform the patient that it's their responsibility to notify the ministry if they have, just like any other condition. Now there's nuance to that. If you're a if you're a commercial truck driver, then there's a duty to report even in Alberta, and obviously you have to take that in the challenge is you often have to look at the whole clinical picture. It's not just about the test, but it might be how sleepy are they. Well, even if they're not sleepy, maybe they have signs of inattention, or they might be at risk, and so it gets pretty tough to tease out. But I think the reporting is quite variable and depends on the clinical assessment. But it really highlights the fact that a clinical assessment is needed to go along with the test to put it into context for all of those reasons, the clinical reasons and the safety reasons. In some of the industries like the railway industry, certainly in the U.S., when you look at commercial truck drivers, there are some really clear guidelines, some of which include more advanced sleep testing to confirm the ability to stay awake. And we do that sometimes for patients when it's not clear whether their treatment is adequate or not. But definitely more to do on that in terms of understanding the disease and all the nuances around sleepiness and vigilance and those kinds of things.
Thank you.
Brian again.
Got one for Joanne. You mentioned 570 pages or whatever for this report. Lots of collaborators on your team, both internal and external. I'm sure there must have been some good lessons you've learned on how to do HTA in a very complicated project such as this. Anything that comes to mind from a lessons learned perspective?
Lots of lessons learned. This was actually my first HTA project at CADIF, and so from a personal perspective, was getting used to sort of the procedures at CADIF as well as working on this project. I think the key really was to rely on each other's expertise, as well as the experts, the clinical experts that we brought in, Sachin as well as others, and this speaks to this content area specifically, had specialized content areas, dental, surgery, and other things, and I guess this is indicative of this collaboration that is really needing to happen, where it was only possible when we brought everybody together to really talk about how to interpret the clinical findings and all the other findings, because it is really a collaborative effort, because there are so many different interventions from different areas, even in the clinical field. And so I think that collaborative effort is really the learning lesson here.
Yeah, Kwachi.
Kwachi from CADA. The CPAP device will be pumping air down your throat whilst you are asleep, which seems to be an unnatural thing. What I want to know is, does it have any long-term health effects? And the second part of my question is, did you find any patients who got better after the intervention to the point where they were weaned off the devices, or once you are on it, you are on it for life?
Great question. Maybe I'll start with the second one and then come back to the first one. So when we talk about CPAP, mandibular repositioning devices, I mean, these are treatments to control the condition, right? Blowing air in, it basically opens up the airway. When you pull the jaw forward with a device, you're pulling the jaw forward while you sleep to counteract the relaxation of the muscles. So if you stop wearing it, you will go back to having it be untreated again, unless there's been another intervention. So a significant weight loss, for example. How you present that to patients really depends on their particular circumstance. So when someone is really sleepy, it's already difficult to convince people to exercise more and eat better and think about strategies to lose weight. When they're really sleepy and can't even stay awake to do their daily activities, it's that much harder. And so sometimes that isn't a conversation for the first visit, it's a conversation for the follow-up after we've started treatment and seen some symptomatic benefit, and then there may be some motivation to do it at that point. Speaking of motivation, you're right that it is uncomfortable for some people, and because it is an unnatural thing, right? We're used to sleeping with nothing on our faces, and now we have this mask that's pretty tight-fitting, etc., or the dental device. So it can be sometimes motivating for people that aren't tolerating it quite so well or don't like it to say, okay, I'm going to really kickstart the lifestyle side of things to try and get rid of the sleep apnea, or at least reduce it in severity enough that symptoms are less of an issue, or maybe we get into a lesser severity where some of those health risks are less of a concern. In terms of long-term benefits, long-term risk, there isn't a whole lot. Generally speaking, they're pretty safe therapies. If you're wearing the mask and it doesn't fit properly and it's too tight, you can get some skin breakdown. Some people have the lines on their face that don't necessarily go away. Some of it is about just making sure don't go away, meaning over in a couple of hours. Depends on is the mask fit appropriate? Is the pressure set appropriately, et cetera? So, that attention to those clinical details are important. With the mandibular repositioning devices, there's a little bit of concern around, they pull on the teeth and essentially on the jaw. So to what extent does that, change the direction of teeth and that? But the dentists that I've worked with, they often have exercises you can use, a tongue depressor and some dental exercises to kind of just oppose that force. Now, when we talk about treatments that are curative, surgery in theory would be a procedure that gets rid of sleep apnea, right? You fix the underlying anatomical abnormality, if that is the only problem, and there are other biological reasons why people might have sleep apnea, but if it's an underlying anatomical abnormality that you fix, then sure, you may actually cure sleep apnea. The question, though, is does the evidence support that to the extent that we'd like it to be able to recommend it, as a first-line therapy? And I'd say the answer at this point is still no. But I think we're hopefully on the verge of some more studies to help us understand that a bit better.
So maybe just check in with if there are any questions online, and there are some. Janet, if I could just get you to read one.
This is a question from Alyssa Hayes from Health Canada. She's asking, what do you recommend for patients with normal weight and mild OSA severity who are systematic, for example, have daytime sleepiness?
So I think that it's a good question, and I think when I was talking earlier about symptoms, I think that in and of itself needs to be a consideration, right? If somebody has arthritis, I'll just use as an example, we will offer treatments to help with symptoms, pain, that will help function, right? So I think of treatments for sleep apnea in the same way, that if we have patients who have symptomatic mild sleep apnea, we should be thinking about offering them therapy for symptomatic benefit. The evidence is tricky because it includes different severities, and we look at other cardiovascular risk and things like that. Those are the scenarios that are a little less clear. But I think if somebody has a symptomatic disease and we can treat the symptoms to improve downstream impacts on quality of life, et cetera, we should. I don't know if you want to, Joanna, do you have any comments on that or from the review?
I think that is consistent with the HTERP recommendations. So in most cases, for mild OSA and no case of obesity, then no active treatment, but it has to go with the clinical sort of implications. And if there are symptoms, then you do want to take care of those. And so.
I'll just add, sometimes you can, there are patients who have, sleep apnea tends to be worse when you lie on your back for a lot of patients. So sometimes, and the evidence probably doesn't support this as well as we'd like, but sometimes, you can have patients sleep on their side if it's mild sleep apnea that seems to be symptomatic. And there's all sorts of devices out there. So the simplest one is stitch a tennis ball in the back of your T-shirt or your pajamas, and so you kind of learn over time to just not sleep on your back because it's uncomfortable. But there's sleep shirts, the foam pads. There's all sorts of things out there. But the point is that trying to promote positional therapy could help, but that's only in select patients.
I'll just quickly add, we did come across a lot of studies looking at those tennis ball therapies, and they were quite effective, so.
Yeah, and time for another one.
Okay, this is from Suzanne Solvin at Pacific Blue Cross. She's asking, did the economic evaluation consider the lifespan of the devices and ongoing replacement of the devices over time?
I think it did, and I'm actually going to redirect that question to our health economist, Bernice.
No pressure.
Yep, so we did speak with both the clinical experts and got an idea in terms of what the typical lifespan was for the device, as well as replacement costs for it. So for surgery, because it is a permanent solution, there was no replacement cost associated with it, but for both mandibular advancement devices as well as for CPAP, there would be. And so we took what was, according to the clinical expert, what was the most realistic scenario when conducting those analyses, and we did factor it in.
As I recall, I think that included things like mask replacement. It wasn't just the whole machine, but masks need to be replaced a little more frequently, things like that. So I think that was also in there.
Yeah, we're lucky to have most of the project team in the room with us today. So I'll look to the room for another question, and then if not, I think we can take another one from, yes, Louis.
Hi, Louis Derizadek from CADIS. So the question is for Sachin. So first of all, I'd like to thank you for bringing the policy implications into the debate. I think it's very relevant, and all the questions of funding and reimbursement and policy making. So I was part of the initial conversations with the jurisdictions on what kind of issues that we're experiencing. And there's something interesting in those jurisdictions that do fund and do provide CPAP, for instance. They experience a kind of pressure because of the large amount of demand they are experiencing, maybe because of over-treatment or over-diagnosis or whatnot. And because of that, they're looking for ways to prioritize treatment and manage wait lists, for instance. And maybe add or specify criteria for reimbursement. So I was wondering, what's your perspective on using the CADIT report, CADIT recommendations to help these decision makers?
Yeah, it's a great question. So I think there is absolutely the risk of opening the floodgates, if you will, in terms of demand, most of which is, I would suggest, given how common the condition is and how, frankly, sometimes, unpalatable the treatment might seem to patients. Most of it is probably appropriate, but there are some that, they get a diagnosis and they want to wear the treatment. It's maybe a bit of an overcall. I think that there are ways to address that that are actually in use in some jurisdictions and for some funding programs. So, if you look at, in Alberta for patients with more complex sleep disorder breathing, so not just obstructive sleep apnea, people that need more advanced therapies for more complex forms of breathing disorder during sleep or oxygen, there actually are adherence criteria. So, you have to demonstrate that you're actually able to wear the therapy. So you don't just get the machine and put it in the closet and there you got your free machine, right? You actually have to demonstrate that you're wearing the treatment to maintain the funding for the machine. So the machines actually get taken back. Now, that's not always that clean, cut and dry, but at least it brings some other factors into the conversation that might address that issue, which is, maybe we need to think about, a minimum use criteria or some sort of clinical criteria that helps us determine whether a patient is actually using the machine and deriving benefit. And so that's one example. I think the NIHB actually uses that for CPAP funding as well for Indigenous populations as well. They have adherence criteria that inform the decision to fund. So I think that would be one way, and I think the report does address things around adherence to therapy and the patient perspective. And I would, I guess, include in that patient preference. So we're talking about CPAP a lot when we talk about funding, but I'll come back to the fact that there are other therapies and preference may actually play a role as well. And I think the report would support that based on those patient perspectives. Again, if you want to wear one therapy over another, or use one therapy over another, that probably means something in terms of whether you're actually going to use it.
All right, we'll turn to online if there's another question.
There's actually many.
Oh, great.
This one's coming all the way from Texas, the Texas Tech University Health Sciences Center School. They are wondering if you can comment on the evaluation of home versus sleep center diagnosis and therapy adjustment in terms of adequacy, efficiency, cost.
I was actually wondering how long it would take for this issue to come up. And we did talk about it at the committee and had to sort of, I think as I recall, sort of put a box around the analysis that was going to be done because it does become like layers of an onion. So I'll just acknowledge from the beginning that I come from a province where there's a lot of home-based testing and ambulatory diagnosis and titration. And I think that, probably our person asking the question is in a similar sort of place because in the U.S. there's a lot of this going on as well, and across the country, probably Ontario being the main exception, there's a lot of ambulatory testing it's probably the main way that people are getting a diagnosis. So there are definitely studies that have looked at clinical outcomes, have looked at cost effectiveness of ambulatory pathways. So these would be home-based tests that are specifically looking for a diagnosis of obstructive sleep apnea, so home sleep apnea testing, as opposed to the in-laboratory tests that would allow us to look for other sleep diagnoses. So home sleep apnea tests in patients with moderate to high pretest probability without any other significant comorbidity that might impact the test interpretation. So confirming a diagnosis in a patient with a moderate to high pretest probability. When you select the right patients, I think that the evidence would suggest the pathways are very effective. You would then be using auto-adjusting CPAP machines to figure out what the right therapy is, as opposed to doing a titration in the lab. And there are studies as well that demonstrate that they're cost-effective. It wasn't something that we talked about it in the meeting. I think it is an important consideration, particularly when you factor in things like travel for patients and other costs that may come up when you're looking at cost effectiveness of a therapy. The diagnostic pathway is an important consideration, but it was something that we left out of this analysis. I think it's a great question for the next big report.
All right, so I think with some of our future work laid out for us now that draws us to the end of today's session. So thank you to both people for asking their questions and to our speakers for their thoughtful answers. And you've certainly provided a lot to think about and an excellent overview of OSA and what this work means for clinicians. So this brings us to the end of today's talk. This session has been recorded and video will be made available on CADA's website. So check that out at a later date. And an evaluation form for today's session will soon be forwarded to you as well. So thanks again to Joanne and Sachin, and please join me in thanking our speakers.